N3 is a rare entity. It pops out, right? But most of what clinically is an N3 for us is radiologically a bulky N2B. So that is common, and N3 is negative. How sure are we that, getting out the N3 is correct, and shouldn't bulky N2B be in there also?
Yeah, so I think one of the things that we are looking at is, and there's N2B and N2Bs, right? The N2B that are very few nodes, and then N2Bs that go all the way down to the supraclap area. And so for the HN002, we actually said that we only allow for N2B with up to 3 nodes and up in the upper neck level 2. Anything else below that, we don't allow them to go into the radiation alone, enroll into the study, enroll to radiation alone. And I think there's some data, at least retrospective data, showing that the lower the node that you go in the neck node, the higher risk of distant metastasis. And I think we need to do that kind of study to test for that. But yes, I agree with you.
So it's a much more comprehensive revision of the staging, not just the size of it.
I think so. I think we need to do that.
Could I also add to that, if I'm allowed to get into the discussion, is that radiographic staging of the neck is poor. And so all of the studies that we've taken this from is from, non-accurate neck staging. So 3311 will hopefully, as a kind of, additional benefit, give us some idea of radiographic versus pathologic staging in the new disease in HPV positives, in part because really what I thought about when you were asking your question, Everett, was a lot of those N3s are just big cystic nodes. And is that one node where the cells were necrotic and you've got a little rim of low volume cancer around the edge? Or is that really matted nodes where multiple nodes with gross extensive ECS have merged into one big N3 mass? And I think those prognostically are different. And so perhaps we need to better biology. Certainly, I can tell you on the 3311 trial, we've had folks enrolled with a couple nodes up front, and they'll have 15 positive nodes when the neck specimen comes out. So I think we need to try to understand the disease better, and everything we extrapolate from the HPV negative world into this new disease, I think we have to sort of almost relearn a lot of it.
Can I ask about that too? I've participated in a number of projects where and I don't know if this is on or not, where the patients have been staged surgically or radiographically, and whereas the surgical nodal staging correlates very clearly with survival the way you'd expect, the radiologic staging only doesn't always correlate with survival at all. So I have some real concerns about changing the staging system. In that setting, it's very confusing to me. There's a big difference between surgical staging and radiologic staging.
One cannot argue with the 0129 data, 0522 data, which was radiographic staging and 90+% survivorship for HPV positives given chemoradiation. So the data those are driven from are usually radiographically staged patients. But this is where the disconnect comes for me, is that we know, as Neil points out, there's strong, accurate staging information that comes from a surgical pathology specimen, and yet we have these large randomized trials, usually from the RTOG, showing great survival using radiographic staging. So, I do think we have clinical data, and we don't yet know what an HPV positive patient with 15 nodes means, but they exist, and hopefully the 3311 will give us some specimens that we can then follow patients, realizing that it's, those patients will get chemo.
Quinn, to your first talk, so you showed a number of really exciting molecules. They work as radiation sensitizers, but it's always unclear how we should translate that into the clinic. So how do you know something is working? And we've tried to re-radiate and do other approaches to that, but are there better models that could be a little bit more reliable, or better ways of early clinical testing short of a randomized trial that allow us to move forward with a little more confidence than just preclinical data?
So we struggle with this all the time, and we've talked with FedDRUX to try to kind of harmonize the preclinical model in terms of try to do it. And I think the way to go is orthotopic. A head and neck cancer model. And so many of us are now heading toward, I think the sub-Q xenografts are not going to be the way to go. And I think, Mike's field or your place is doing some sort of transgenic head and neck model with HPV positive population. I think those are the models that we should eventually go and test. And I think we need to be more rigorous in our preclinical testing.
I had a question about that too, just in follow-up, and the goal is to be a little stimulatory here and not to have you represent the entire targeted therapies field, but maybe with Neil on the stage, when we see these genomic alterations, does the issue of allele frequency of that alteration tell us something about heterogeneity and the likelihood of a single inhibitory TKI?
So are you talking about the like ATM, ATR, or?
So what the immunologists in the room said for decades when we watched the targeted therapies world is, the tumor's heterogeneity is going to prevent a single inhibitor, even though you might see the alteration in phosphoAXL or phospho-EGFR or SARC, it's going to prevent a single inhibitor from benefiting. Now we have all of the detailed genomic data, and actually we get some quantitative numbers about the rate of mutations and activation, and so I just wonder, is this what we were doing for 10 or 15 years to add this on and try it in these trials when we know that it's a very small subset that actually have the relevant biological alteration?
Well, the sequencing is cheap. The cancer is a genetic disease. I mean, you can't argue against knowing more about the tumor. Most driver events, are present in all cells. I mean, EGFR is somewhat complex and for lots of reasons, and in particular, but most driver events persist throughout the life of the tumor. And when you talk about tumor heterogeneity, if you look at most of the literature on tumor heterogeneity, most of the heterogeneity is a non-coding sequence. I mean, there are clearly exceptions, and EGFR is one, and there are some others where tumors feel evolutionary pressure to gain or lose certain alleles. But overwhelmingly, it is very, very hard in a heterogeneous sample to find coding variants in the different METs, the different regions of the tumor.
So actually, a couple questions. First, actually a comment on your survival. That's a great curve on how quickly you start therapy. I don't know if you remember, but in small cell lung cancer, they actually had the same thing as from the diagnosis initiation radiation and then chemotherapy starting, that every week you delayed it, it actually dropped survival by like 1.3%. So, I mean, kind of small, but it really, I think, it just illustrates your same point, which I think is very important. One thing, the AXL pathway, which is really, it's kind of an interesting pathway, but it seems like it's not necessarily a driver pathway, but it's called nudge, but it's a bypass pathway. So, it doesn't affect, like if you just use an AXL inhibitor, they don't seem to potentially have dramatic responses, but they may be a combination. So if you have AXL, do you think that is going to be a combination drug, that it's going to be added with something else to hit PI3 kinase or hit mTOR at the same time? Is there something else you're going to want to hit at the same time? Because it just doesn't seem like AXL typically is a driver. What's your thoughts?
Yeah, so I think the AXL has been tested quite a bit in more ovarian breast cancer model.
And I know AML is a big target potential for AXL too.
Right, and so in those models, they actually monotherapy in established preclinical model, whatever is worth it is, it actually decreases the burden of distant metastasis. It's a question, but I do agree. I think it seems to be something that you probably do in kind of an adjuvant follow rather than by itself.
Yeah, when all of a sudden, if you're not responding, this may be one of the bypass pathways that you got to block it after. A little bit on Dr. Hayes, on your development of assays. It was fascinating when you're talking about, the fact is that almost any lab can start putting some of these together, but then what gets reimbursed, what can be talked about, and just the cost issue in the development, because I think you're exactly right, and I want to get your opinion on where it should go forward, because I mean, full genome sequencing, what was it, $30 million when we did it the first time, and now you're doing it for, 500 to 1,000. So the problem with a lot of these assays is they can't be reproduced very cheaply by others. So how do you keep a financial incentive to develop innovative assays, but then also get them so they can be adapted and used, as you mentioned, for EGFR, Dr. Bunn, should we be, we want to use it where it's helping patients. So what's your solution?
The way forward is going to require quite a bit of work. I think, there's financial, I had a thought during Dr. Crawford's talk on Thursday that occasionally the FDA will require an additional trial after, the definitive trial after approval. And, I wonder if, especially in the world of, expensive drugs, if it could require biomarker trials, and I'm sure I'm not the first to have this idea, to require a biomarker trial after the definitive trial, and to really put some teeth into it, because I don't think there's any way around, development of a quality kit, a kit that you can sell that's been QC'd and all this is going to require, millions of dollars. And if you look for the sources of funding out there for, that level of funding to develop the kit, that's after the science. I mean, science is long gone, you've established that. I think it's going to take those kinds of, policy decisions to move things forward. I think a lot of this is at the policy level.
And it's difficult because, if the kit's going to cost millions of dollars, you got to get a return on your investment. So the companies are going to have to get that back, which means they're going to have some exclusivity, which is then going to drive the cost up. I mean, it's what happens with drugs. So all of a sudden then, you drive the cost up and then, it's not worth.
Well, I'm not sure that it does. I mean, I'm not an economist, but if you develop a biomarker that, that just, even Tenge's, nanostring signature for I forget which, for Pembro, I think. I mean, he essentially argued, and I think he's probably right, that he can eliminate a certain fraction of patients, maybe half the patients that have a very low likelihood of benefiting. It doesn't mean you would completely deny them the drug.
Yeah.
But, you just cut half the utilization of the drug with the biomarker, and I said the biomarker development costs are, maybe 30 million. I mean, these are other people's numbers, $30 to $100 million, but you cut out half of the usage of the drug, and you increase its effectiveness by selecting. I think that may be neutral.
Oh, no, I agree with you in terms of it may drive down costs if you, like, from drugs or other therapies. But the question is really the development, because it's easy to actually potentially bring in somebody else to do that nanostring for a low cost. So, if you do give that, if you have that one company, you give them exclusivity, well, yeah, you may drive it down and that, but what you really want to do, drive down all costs and drive down, if again, people can do a local, nanostring is similar and they can find the same thing and it's costing hundreds of dollars versus if I patent it, I spend $30 million and I patent it and I have to make that a $5,000 test for some period of time.
Well, I think, you want there has to be a business model for all of this. Otherwise, it's not going to go forward. So
Exactly.
I think somebody has to make some money somewhere, or no one's going to do this. So I'm not against a business model, and I think at the policy level, we just need to figure out what's tenable.
Exactly. It's very difficult. I just wanted to hear your thoughts. And the last question I have is it's really into the sentinel node piece and your node dissection. One of the things in the colorectal literature that they found is that when they said, there's the same thing, is the more lymph nodes resected, the better the prognosis is. You got to get it, they kind of found it. But what they also found is when they went back, it depends on how much the pathologists were looking for lymph nodes. And what they found is that many specimens, that the pathologist just went quickly through it. They pull out 2 lymph nodes, they were negative. But if you really did, you could pull out 35 lymph nodes and then maybe something is positive. So that was part of where they found it. Is that the same thing when you looked at your distribution, that some of that's the pathologist and how deep they're looking for lymph nodes in the specimen you're sending, or in head and neck, is it different than colorectal where you basically, they know them if they're there and it's really the surgical technique that is the reason they have more or less lymph nodes?
Yeah, so if I was reporting on others' data from RTOG trials. So in those studies, we're generally stuck with a pathology report at the cooperative group level. So it's hard to know what the pathologists were doing, but clearly there's a diverse and broad group of accruing sites in the cooperative group trials. And often they're only accrued to the trial, post-operatively when they have features that would qualify them. So we don't have very good quality control over the pathologic analysis. What I can tell you from looking at our own data and studies that have done the corroborating dual analysis, looking at a standard neck dissection, is that there is that it's pathologic sampling that is what sentinel node brings. Two things: pathologic sampling, there's more step sectioning and not just a bilobe node, and also then really tracking the true metastatic path and the first draining nodes. And I think what 18 plus nodes is really doing is it's enforcing this sort of inherent requirement that you're broad and comprehensive enough that you get the relevant nodes in your specimen. The other, when 1 or 2 nodes are positive, the other 16 were irrelevant. You didn't have to remove 18 that day, but you needed to if you weren't going to analyze the metastatic path and behavior, which sentinel node allows us to do. So it is hard to know whether the sentinel node technique is valuable because the drainage pattern is the major benefit of the procedure, or the step sectioning, careful look, immunohistochemistry. Again, we don't get any of that with standard pathology. They just don't have the time or the cost involved to go through every node. They just cut it in half and look. And as we know, a node that's a centimeter might have 2 millimeters embedded, buried deep in that, and not be at the face where they cut it. It's like finding a raisin in a loaf of bread.
Yeah.
You have to slice it up.
I have 2 questions. One is for Dr. Lee. Regarding the DNA inhibitor study, and it's a little bit counterintuitive when one thinks about at least some of the data with PARP inhibitors would suggest that inhibiting the non-homologous end joining pathway where DNA PK is very important could actually be counterproductive when you're trying to induce DNA damage and cell death. And I'm wondering whether or not, at least based on preclinical data, how robust the evidence is for that strategy of inhibiting DNA PK.
Yeah, I think there's going to be a lot of presentation on this at AACR upcoming, so I encourage you to go there. I can't disclose the preclinical evidence until it's presented at AACR, but the preclinical evidence is pretty robust in that, so it is intriguing in terms of lack of normal tissue toxicity and pretty good tumor control.
The second question I have is actually for both Neil and Bob. Which is, at least now, the NCI is open to the idea that maybe we don't need to worry about the primary site of origin, just focus on the genomic profile of tumor and then try to target the driver mutation irrespective of where they're coming from, a la NCI match. In your RNA sequencing technique, have you seen any commonality between the virally driven HPV, EBV driven nasopharynx tumors? And related to that is whether, going by the presentation 2 days ago about inflamed tumors being surrogate for maybe strategy for immune-directed therapeutic strategies.
So I think you had a very, important questions that you ask. Are the virally driven head and neck cancers, do they have common etiologic or pathogenic mechanisms that may allow us to make a basket trial for virus-induced cancers? I think the answer is probably no. I think the commonality is not just that they're viral, but that they occur in the lymphoepithelium. And often we can see some HPV in the nasopharynx in North America when it's EBV negative. So I do think there's something about viral infection in a lymphoepithelial subsite. Although we have some rare, larynx or oral cavity, that's, I think, what screams out at me. And I think we don't understand the biology. So it's not that we can target the virus similarly, because EBV and HPV are really quite different. I think it's more that understanding why a viral interplay with a lymphoepithelial tumor microenvironment permits malignancy in that subsite of the head and neck. If we figure that out, I think then we'll come up with a common targeting strategy. But Neil or somebody yesterday pointed out this elephant in the room, maybe it was Tanguy, that you know, the HPV positives are not the screaming PD-1 pathway success that we would all have expected if it was just, you know, tolerance of the oncogene-specific antigens. I think the data in EBV is less, but it will be coming. I know a number of companies are interested in studying this disease in Asia. So we need to understand progression a little bit better and immune escape in the virus-driven cancers. So we don't understand the etiology, and we don't understand, I think, why some are responding to the immunotherapeutic strategies. But I think it's ripe, and it'll be there in the next few years.
So just add a couple of points. Number one, nasopharynx cancer has not been characterized as well as head and neck cancer. Several points. Number two, we still have really relatively limited data on HPV positive genomes. There were roughly 30 in the first TCGA report. There's actually another 60 that no one's looked at, so if anyone's got some time, we're kind of going to try to restart TCGA 2 for head and neck to look at so we'd have a total of about 60. I've reviewed a couple of NPC papers, but other people don't like them as much as I do, so I don't think they've gone forward. I'm pretty sure that one thing that's clear is that for HPV positive tumors, they nearly universally have wild type P16 and P53 and RB, and I think that NPC is also wild type for P53.
Yeah, they're wild type P53. They only very few of them get mutated at a very late stage of metastatic disease.
But there is one gene that came out that was really very interesting, and almost no one's asked me about it, and I think it's probably because people don't know that much about it. It's a gene called TRAF3. So TRAF3 had, in our 30 patients, I think there were 5 stopped TRAF3 mutations. There were several other homozygous deletions, that's like a rare event in the genome. And TRAF3 had been previously reported to be mutated in NPC, which I don't know how they thought to look, and and this is an interesting gene in the interferon pathway. Actually, it's attributed to several pathways, so I think that's one of the issues. It's not clear what pathway that gene is in.
And the rate in HPV negatives was like 0.
Yeah, so this is clearly, looks like it's a viral specific mutation. And I had hoped that it would also be very common in cervical cancer, and there actually are TRAF3 mutations in cervical cancer, but it wasn't nearly as big a deal as it was in.
I think in cervical, the TRAF3 is ubiquitinated and degraded, so
Okay.
inactivated in a non-genetic way.
So at least one pathway, and TRAF3, depending on which pathway you think it's in, may be targetable.
So just looking at the distant metastases with the HPVs, cisplatin on its own has some systemic activity, but in my mind, our group was just wondering, well, is it more that you have better control of the lymph nodes in the areas, and that's what's preventing the distant metastases? How much systemic control do you think that the cisplatin type is adding to the treatment of these people?
Yeah, I think that's a good question. I mean, with Charlotte Jacob, I think Everett may remember a long time ago, we did a study where they randomized patients to 1 versus 6 doses, the monthly cisplatin. And when you give a higher dose, longer time cisplatin, you actually have decreased distant metastasis. We agree there's a controversy in the field whether distant metastasis is decreased with cisplatin. We know from the larynx cancer data is that it does decrease, compared to a patient treated with surgery followed by radiation versus chemoradiation, the pattern relapse change because you have less distant metastasis or more local regional failure. So I think we need a little bit better treatment for distant metastasis in these patients. The question is, how do we select for the patient? As you can see, out of 800 patients, 750, only 80-something fail distantly. So we can't expose the 750 patients to all chemotherapy to focus on that 80 patients. So that's where the issue comes in.
Maybe the
I
last
have
question.
a question for Dr. Ferris. Why do we choose 18 lymph nodes for the threshold?
Well,
I will
yeah,
jump in.
please,
a little
thank
bit.
you.
Yeah, because I was involved in that study. So what we do is we kind of look in addition to the cutoff that's out there in the literature, we also look at the cutoff that give us, you can look at the hazard changes. And so it looks like the cutoff in the literature is anywhere between 12 and 20 lymph nodes. So we look at in that within range between 12 and 20 lymph nodes, and 18 give us a better hazard, the biggest hazard change. And that's why 18 got settled out.
Thank you.